Um, so I'm talking about misophonia this morning. Um, so just some psychoeducation on misophonia. Misophonia um, means the hatred of sounds. It's characterized by a decreased tolerance of specific sounds or stimuli, not necessarily associated with like the loudness of it, but really like the kind of specific kind of sounds. We see increased negative emotional, behavioral, and physiological responses to what most people would say are normal sounds that we're going to hear in our day to day life. They typically tend to be repetitive human made sounds, although from this list over here, we can see it's not always just human made. We think about like ticking of a clock, um, or like the water dripping. It could be like the air conditioning unit turning on. Um, Also, those common triggers that do tend to be the chewing of food, heavy breathing, or coughing or sneezing. We're in that season right now where that's a really common sound people are hearing and can have a big reaction to. Um, and I don't just mean like having a reaction to, right? Like if we hear someone coughing and sneezing, a normal person during cold and flu season might be like, ew, like I don't, that feels uncomfortable. But we're seeing um, a really more than excessive response to these kinds of sounds. Can also be a difficulty with focus and attention during that trigger sound, can impair performance, whether academically or with work. Um, there can be varying levels of reactivity and self awareness. So some people really respond to this so automatically, they're not quite. Um, it feels like one big exposure already. Absolutely. Just talking about it. And a lot of times exposure therapy does start with that, right? Just talking about it before we get to that higher end of the exposure hierarchy where we're actually exposing ourselves to certain sounds, which we'll talk about more later. But um, and it really does trigger that autonomic hyperarousal. So like I said, it's not just a normal like, but like that fight or flight kind of stress response can really kick in when we're hearing these kinds of sounds. We can have emotional feelings like anger. The heart can be beating faster. We can have behavioral actions like glaring, and some more just thinking about the responses to those trigger sounds. It can have a whole range of emotional responses. It can be anger or irritation, it can be anxiety, it can be disgust, it can be sadness. And so like that's where like we'll look at where CBT will come in later. Excuse me. And can have those physiological responses like the muscle tension, that clenched jaw, and the increased heart rate. We can see sweating. Behaviorally, we can see people like leaving, like getting up out of their chair, leaving the room, trying to get away from the sound. But in a way that's excessive. Like we really like one of the big cases I will talk about later for me was when we're in school, we can't just be getting up out of the classroom and leaving because someone's chewing gum next to us. Um, Asking other people to stop and looking for those kinds of accommodations. Um, Verbal or physical aggression, like really getting like we see that anger and the irritability coming out, talking about other like trying to control other people's behavior. We could get those dirty looks, like we said, like that glaring, um, mimicking other people's sounds, just trying to put them down for chewing food, crying. Um, and then we can have the cognitive responses too, worrying about what like how I'm going to pay attention in class when this thing is going on. Well, how is my performance going to be impacted by this? That difficulty concentrating, blaming others, and saying like if they would just not do that thing, then I would be able to pay more attention and show up better here. Um, Responses can be influenced by perceived control of or a relationship with the person making the sounds. Um, So, like I said, thinking about bringing in that cognitive behavioral therapy, um, I'll just um, that like a lot of times their exposure and response prevention is something that we can do um, with an asterisk, which we'll talk about in a second. But also, a lot of times it kind of devolves into the meaning making we're having with the sounds. Like my friend is chewing gum, and it's because they know I don't like it, and they keep doing it anyway, and they just don't care about me. And so, like looking at ways in which we can um, address those kind of cognitive responses to decrease that distress there. So, how to diagnose misophonia? First of all, misophonia is not an official diagnosis in the DSM. But like anything else, to diagnose it, we're going to gather information, right? We're going to look at what are the triggers that cause the kind of response that we're seeing, those cognitive, behavioral, emotional, and physiological responses to the sounds. What are those? How do we gauge the severity if that is a normal response to an annoying sound, or are we seeing something that really is more excessive, which is a little bit subjective? um, the context of the responses. So thinking about how the sounds are produced, does that matter? Does the environment matter? Is this only happening in the school environment? Is this only happening in the home environment? Um, or is it happening everywhere? Uh, Physical and emotional states, like being tired or irritable, how does that affect the responses that we see in response to the sounds? And then sensory information in general. Is there a sensory sensitivity? Um, that is that associated specifically with misophonia, or are we looking for other conditions or other comorbid conditions like some kind of obsessive compulsive disorder? Agoraphobia is something that sometimes causes these kinds of reactions. A sensory processing disorder, which, like misophonia, is not an official diagnosis in the DSM, but related to autism spectrum disorder, in which we see those kinds of sensory uh, sensitivities, and a reach for control in ways that some people would um, say is excessive or rigid. Um, so, since misophonia is not an official diagnosis in the DSM, I'm typically diagnosing something like generalized anxiety disorder or major depressive disorder or adjustment disorder, depending on the context and how it is showing up in relation to other things going on with them. So, like I said, if we're having so much anxiety about someone chewing gum next to me in class that I'm so worried about whether or not I'm going to pass this class and whether or not my friends like me, and worry about all these other things, we're going to go maybe with a more generalized anxiety disorder, versus if I'm seeing more of the depressive symptoms of like get really shutting down and sad about the fact that this is bothering me so much, then I might go more in a major depressive disorder. So that's just up to clinical judgment and seeing how it actually fits in with other kind of symptoms you're seeing. So, like I was talking about with exposure and response prevention, the treatment for misophonia, habituation based ERP, is actually not recommended for misophonia. So we're not just listening to the sound over and over again, because typically clients don't habituate to that sound, and the repeated exposure by itself can actually make arousal worse. So we really want to modify that exposure and response prevention by pairing it with cognitive behavioral therapy or acceptance and commitment therapy or relaxation and counter conditioning kind of skills. So we can do that by doing exposures while using shaping behavioral responses, like listening to a sound while doing a power pose or a dance, or using humor, so that we can start with behavioral therapy, kind of like uh, adjusting my behavioral response to it, that I'm pairing it with something that is a more pleasant. Exposures that explore client control. So using things like rating and scaling distress, just like an exposure and response prevention, looking at my SUDS. What number do I feel when I listen to this sound versus this sound? Using those grounding skills. So sensory grounding, cognitive grounding tip, I'm sure those are things that everyone's familiar with. Um, so we do want to have good handle on those skills to use during exposures versus the habituation based, where we don't want you to do those things. We just want you to feel that feeling and get used to it and habituate to it. We actually want to use grounding skills with misophonia, so that we can navigate through it and observe rather than obsess with the sound. Um, so a lot of times that is what happens with misophonia is I'm obsessing about the sound, right? I'm glaring at the person, thinking about like, why won't they just stop? Why won't they just stop? And I want to observe what the sound is and allow it to just be a sound. Leaves on a stream kind of thing, right? Like the sound is here. It doesn't have to be a thing that I'm making so much meaning on, that they're doing it on purpose to bother me and that I can't handle this situation. Um, and so that goes along with that thought challenging too of like, what meaning am I making out of this? The classic ABC of the antecedent is happening. What is my belief about that sound? If I believe they're doing it on purpose to bother me, the consequences might be that I'm really anxious and I feel like I need to control them to stop it. Versus if I believe that they're chewing gum because they like it, it has nothing to do with me, I might be able to change the consequence to focus on my relaxing skills and grounding skills. And then counter conditioning, again, with thinking about if I expose myself to the sound at the same time that I'm trying to focus on a pleasant sensation, um, or even neutral. Neutral is better than that obsessive focus on what's going on. Um, So that is how we want to utilize exposure and response prevention when we're dealing with misophonia specifically. Again, this is just CBT triangle, including the physiological sensations in here. Like I said, um, if we're hearing the sound and the emotion comes up that I'm angry and I'm irritable about it, I get that muscle tension, my heart rate's going up. My behavior turns out being dirty looks towards someone because I'm thinking they're doing it on purpose. I'll often toss it to the client and ask, what do you think you have the most control of over of these four categories? Our physiological sensations, we really don't have that much control over. We can breathe and we can do some grounding skills to a little bit change some of the physiological sensations, but them happening in the first place, we really have little control over. And same with emotions. We kind of have little control over what emotions come up in the first place. So really between thought and behavior, which does the client feel like they have more control over, and how can they interrupt that the best themselves to start changing the whole dynamic of the CBT triangle here? Um, so thinking about more exposure work here, attention focused exposures. So thinking about the skill domains, if it's attentional, like, can I pay attention to doing a worksheet while I'm listening to the sound? Behavioral, can I notice my behavior in response to the sound, like the glaring, like the getting up and leaving the room? Can I challenge myself to do a different behavior in response to that when I'm practicing the exposure together? The psychological cognitive, as we're listening to that sound together, can we talk about like what is happening in my thoughts? And can we talk through how to reframe that together, use that CBT together? Um, and then interpersonal, I think again comes back to CBT and acceptance and commitment therapy, accepting that I am going to get really irritated when I hear certain sounds. And how can I use my values? How can I use interpersonal skills to maintain my relationships in response to that discomfort and that distress? Um, and then time in relation to the stress situation. How can we time how um, before the trigger, timing before the trigger is introduced, during and after? Um, I think just like figuring out how much time I'm spending in that distress, and can I start shortening the amount of time by using some of these skills? That's what I was getting at here. So in summary, again, misophonia is not an actual diagnosis in the DSM-5. It's subjective, it varies in intensity. It is, I think, of misophonia as a diagnosis that, not everyone is aware of. So I think it's really helpful for us as clinicians to know about it and to be looking for it. Um, Although I have had the cases I have had have been people that have heard of it somehow on TikTok or whatever and brought it to me. But knowing that's not an actual diagnosis in the DSM-5, how do we do our treatment plan? How do we do our paperwork to reflect what else is also happening in response to that misophonia? CBT is supported as an evidence-based practice to reduce distress and impairment. Each case is unique. So we're always validating attempts to tolerate and identifying what those maladaptive responses are and trying to teach and increase adaptive responses. Exploring does that meaning making that they're connecting with the misophonia response, and trying to increase the tolerance and resiliency to it. Remembering the type of exposure therapy, if used, is important. That the habituation by itself is likely not going to see the kind of progress that clients want to have. So really being collaborative with the client, identifying the values, what matters, how do we shape that behavior together. And then involving family, friends, and supports can be helpful to avoid unnecessary accommodations. Because as with exposure in response prevention, we see a lot of accommodation from family in particular. And it's great that families want to, be accommodating to distressing symptoms. And at the same time, certain accommodations can really reinforce that belief that this sound is intolerable, this sound is dangerous. It makes sense that my stress response is activating here. So we want to help make sure we are practicing not doing accommodations, so that we can practice the resiliency in the skills. So I have a case that we can break into breakout rooms to do role playing, if that is, I think that's what the plan was for these presentations. But before we jump out into there, any questions, any comments on how this has shown up for you guys or just anything in general? Yeah, Dr. Meehan.
Is misophonia something that like people typically present with, or it is kind of like a combination or like secondary thing to show up?
Yeah, the cases that I have seen, they have the one in particular, like that was what she came in and said, like, I have misophonia and I need to deal with that. And as we talk about it, I kind of see it as a secondary kind of thing. It's maybe like the most distressing thing that she's noticing. Um, but like I said, like the meaning making behind it seemed to be what was really distressing. That idea that people are doing this to me on purpose and how those cognitive distortions show up. And that as we worked through some of those beliefs and with the CBT, that we actually noticed that the response to the sounds decreased, which I think makes total sense going into like the reasoning that just doing habituation based ERP doesn't really work, because it tends to be the meaning I'm making behind the sound that is really more bothersome than the sound itself.
That makes sense. Thanks.
Absolutely. Yeah, Joey.
How might you, like, as a distortion, work through the idea that, like, like I had a client who wasn't necessarily like people are doing this to me on purpose, but it was more they know how I am and they should be accommodating of me. And the fact that they're not thinking about what I might feel in this situation is what's like most distressing. Like how would you work through that or change
Yeah.
that?
No, I think that's a great question. I think that shows up in so many other ways than just misophonia, right? That, you know, other people should be more conscientious of my experience. And I think maybe exploring, maybe through an ACT lens, maybe like just thinking about like empathy in general, that like looking for like those reasons why that might be happening, why people aren't so focused on your experience, that might be looking at cognitive distortions. It might be thinking about like, you know, why aren't people thinking about your experience? People aren't mind readers. People don't know, they don't experience what it is like for you directly. So even if you have expressed that discomfort, it's really easy, I think, too, for thinking about how the brain works, that we're going back to our neural pathways and doing things as we have always done them. And to make a change to accommodate other people is a lot of work for people. And that they don't, it's not that, I guess I keep coming back to like them doing it on purpose, um, but that people spend a lot more time thinking about themselves than thinking about what your sensory experience is in the moment.
And that's probably very true. Also, yeah. Thank
And
you.
I think that's a bigger conversation to explore, though, too, and including the client and getting their ideas on, well, why might a person not be so focused on being conscientious towards your experience? Can we really push ourselves to think of a bunch of different reasons there that aren't just they don't care about your experience? Any other questions or comments before we break out and looking? Yeah, Alexis.
Yeah, well, one, I'm very happy that you're presenting on misophonia, so thank you. And I was going to ask you about when I see clients with misophonia, I often see anger come up. I think that's really interesting how it's such an anger response. And I always kind of gave the psycho ed of like, for everybody, when they hear nails on a chalkboard, like we all get this visceral reaction no matter what. And so I'm curious, like how you talk about that, or like maybe normalize it, or, you know, especially talking about like the anger and misophonia, if you do have any insight or.
Yeah. What immediately comes up to mind for me is two things. Thinking about window of tolerance. That within our window, we can experience different emotions, we can experience different sensory sensation, and that's okay because we're able to tolerate it. And when it goes up into hyper arousal or down into hypo arousal, but I'm going to focus on the hyper arousal because we're talking about anger. That's where we see the anger and the tension and the stress and the fight and the anxiety. So that's a normal reaction that humans have. And how do we notice if we're outside of our window? And what skills and tools do we have to bring ourselves back down into our window? And then also, what are things we can do to widen that window to tolerate a little bit more? Typically there, I'm talking about, the first thing I'm talking about is the physiological things we can do for ourselves to keep our body regulated, which I like to use the SEEDS acronym. How am I sleeping? How am I eating? How am I moving my body with exercise? Am I following doctor's orders and taking medications I'm supposed to be doing? Am I socializing? Or is there substance use that needs to be addressed? And then I also thinking about the acute stress response versus a chronic stress response. That so typically, the sound of a chalkboard, I think, thinks the same thing as that I'm going to have that acute stress response. Like if I'm driving and something someone cuts me off, and I get that acute stress response of I get tense, I get a little bit tingly, I think something dangerous is happening. And I think the same thing can be happening here when like we hear that sound and our stress response goes off, we have that immediate reaction. And when we think we're in danger, we might react with anger because we might be going into more of a fight kind of response here. Ideally, the goal is once I recognize my stress response has gone off, that if something dangerous is happening, I do it, I fight, or I run away, or I wait until the dangerous thing is over. And then a lot of times, like I'm driving, someone cuts me off, it feels like something dangerous happened, but it didn't actually. They drove on, nothing bad happened. And then I come back to baseline after that. And then so sometimes can be a problem, I think, especially with misophonia, where we get into that chronic stress response where we struggle to get back to baseline because of the meaning we're making behind it, that this is something out of my control. It's going to keep happening. They're doing it to me on purpose. They don't care about my response. So it just feels like this inescapable stress versus something that I know that the danger is gone and I can return to baseline now. So again, I think that's where a lot of the grounding skills can be really helpful to help us get back to baseline.
Great, thank you.
Absolutely. If there aren't any other questions, to go over the case I have to support you guys in having a role play and someone being the therapist, someone being the client, and how you might talk through this case together.
That sounds awesome.
All right. So names are changed, details are changed, or this is a case that I have dealt with. So Ariana is a 17-year-old white cisgender heterosexual female. Is currently attending the local high school as a senior. Ariana usually performs well academically and reports feeling mostly satisfied with her group of friends she has classes with and sees on weekends. In her intake, Ariana reports that her mom has asked that she seek therapy to address her irritability and overreactions to her family, including yelling, groaning, and giving dirty looks. Ariana reports that eating dinner with her family has become unbearable as her younger brother chews with his mouth open all the time just to annoy her. Ariana also complains that she's struggling with focus and attention in a specific class. Ariana notices the sounds of other students chewing gum and reports feeling irritable as if the students are intentionally chomping loudly to bother her. She reports staring down students who are chewing to no avail of changed outcomes, and her grades are slipping due to the distraction. Ariana reports that some of her friends will accommodate her by avoiding chewing gum when spending time with her on weekends, but one friend doesn't seem to care that it bothers her and continues to chew gum or eat snacks whenever she wants to. All right, do we have everyone back?
I believe so, yes.
Any reflections on your experience in the role play? Anna.
Yeah, I can just jump in real fast. So Sarah and I were actually discussing how neither of us have had a misophonia client before, or someone with misophonia, not to make it their identity, but we talked about like that idea of how do you validate their experience, especially if it's a kid, like not saying like obviously you want to build the rapport and the whole aspect of, oh, do we really think they were trying to piss you off with the noise? Also utilizing like the expectation of people making no noise. Can we even meet that expectation? And also discussing like the definition of insanity, like is the method client is using helping them? So like doing the same thing over and over and expecting a different result. The glaring, the rage, the anger of like, cool, maybe our little brother or someone else is doing a sound that's annoying to everyone else in the room, but no one's speaking up. Like maybe it's not just the misophonia, maybe someone's really being rude. The glaring isn't working. What else can we do? As well as then the tolerance of like, people make noise. What can we do on our end in our control to make it easier for us? Just, it was very interesting, just kind of us discussing our way around it because of how we've never had a client like that. Trying to even walk through like, oh, this would be hard. Or if this was a kid, how do you even go through it with a kid versus maybe a higher level of understanding with an adult?
Yeah, and I love that, thinking about like assessing for the misophonia, that yeah, of course there are all of these reasons that sounds actually are annoying, and maybe someone is doing it on purpose, and all of those things. So like really figure out, is it misophonia? Is it something real going on? And yeah, being able to make things easier for you in that experience. Jessica.
Yeah, Maddie and I were talking about like the like kind of a mindfulness technique of doing like a background foreground noise. And like you, Lisa, I'm pretty sure like I have this, but and that's something, you know, that I use, you know, it's like playgrounds make me want to throw up. And so I'm just like, okay, what can I focus on? And like, all right, what can we make that's in the background? Like your friend is chewing, it's annoying. Can you play a game on your phone? Can you focus on like editing a photo like of the food that you took or whatever, and just like trying to shift those sounds to make it more of a background and not just like the one thing that's making you want to spin off the side of the earth.
And I love that, naming that as background foreground kind of sounds, because we'll notice like that's the sound we kind of zero in on and obsess over. And if we're using sensory grounding with the hearing sense, like what other sounds do you hear in the environment? And love that. Can we push the annoying sound back into that foreground a little bit more? Any other thoughts or reflections from your role plays? Alyssa.
Yeah, something that I was talking about in my group is it kind of reminds me of like overstimulation that those with ADHD experience, right? Like with noise. So I was like, what's maybe like a good distinction like between like this is more misophonia that, or is this more like ADHD overstimulation? And so we were just exploring that of like they kind of just they seem like they overlap.
Absolutely. And thinking about like the overlap, it's maybe I don't know exactly why misophonia is not in this DSM, but thinking about how much those kind of symptoms do overlap with so many other things. And I don't think ADHD was one I even included in the presentation, but it's certainly a symptom of that shows up in a lot of other diagnoses. So being able to do that assessment and figure out if someone's coming in specifically complaining, saying, I have misophonia, how do we do that kind of assessment to make sure the diagnosis is actually accurate and appropriate? Yeah, Lisa.
Christy, I'm curious, because it sounded like the family in your example, the parents were the ones, or the mom was the one that was really saying, like, fix my kid, you know, not in that sense, but like, this is a problem for our family. And then obviously there was a lot of things happening at school as well. I'm curious how things are going, or how things,
Yeah.
you know, kind
So-
of techniques that you did end up using.
Yeah, so we did do some of the modified ERP together, where we listened to chewing gum, we listened to sniffling and coughing sounds while we were practicing more like the attentional, because she was more this client was more concerned about what was going on in school than what was going on at home. But so I don't see her anymore. She graduated. And she kind of came up with like the observe, don't obsess kind of mantra that helped her through the family dynamics. So we did to explore how there were some family dynamics that were annoying more so than the sounds. So being able to work through some of that together, and kind of like we were saying while everyone else was on the break, noticing that it's a me problem and it's not like them doing it to me on purpose kind of thing, helped focus on, okay, how do I use the skills to focus on other sounds and not focus so much on they're doing this to me on purpose, so that she could tolerate it a little bit more.
So thank you everybody for your participation. Christy, thank you so much for presenting. I know we don't really have like a formal presentation on this, and we are going to see. So some people that maybe don't even know that they have these clients with them right now, or maybe looking at them, in a different way of ways they can continue to support your clients.
Absolutely. Thank you for having me and for having the opportunity to practice presenting.
Yes, absolutely. Thank you, everybody. Have a great day.